everyone, I'm April, and today I'd like to discuss antibiotic resistance and measures that we can use to prevent it. Before we talk about antibiotic resistance, let's talk about some key terms. We'll cover bacteria, antibiotics, and then we're going to define antibiotic resistance and things that lead to it. Finally, we're going to go over an example of something I think could be a potential strain of bacteria that is resistant to antibiotics. So bacteria are present in many places, and generally they're beneficial. However, some organisms cause infections. When this happens, antibiotics are generally prescribed, and the antibiotic is used to combat the infection. The problem is this leads to some side effects. Generally, you're going to be prescribed a broad spectrum antibiotic, which is going to kill the good bacteria and the bacteria that's causing your infection. Side effects would include diarrhea or yeast infections, and of course there are other side effects that are potentially problematic, but those are the big ones. Another thing that happens is you can get a prophylactic dose of antibiotics when there's a concern that a pathogen may become present. We're going to talk about that soon. So antibiotic resistance, it's really caused by the overuse of antibiotics and the underuse of antibiotics. The overuse of antibiotics is when you get prescribed antibiotics for something that isn't bacterial. Some patients will go to their doctor with a virus and expect to get antibiotics because in the past antibiotics made them feel better with whatever infection they had had before. So you can get overuse because you're presenting with bacterial symptoms or because there's patient pressure on the provider to prescribe antibiotics. And underuse is when you take a course of antibiotics as prescribed, but you don't complete the course. And what that means is, say that you have a 10-day course prescribed, but at day 4 you're feeling much better, and you decide, I'm not going to take these antibiotics anymore because I don't need them. Well, what's happened in that scenario is that those first 4 days you've killed off the weakest members of that bacterial community, and the ones that remain are actually the strongest. And once you take that antibiotic out of the picture, those bacteria can multiply. Maybe they've mutated, and maybe now because they've been introduced to that antibiotic, they have some resistance to that antibiotic. So it's always a good idea to, number 1, not use antibiotics unless they're absolutely necessary. And number 2, if you're taking antibiotics, always take them exactly as prescribed and for the full course of treatment. And that's going to give us a reduction in antibiotic resistant bacteria. So one thing that concerns me that happens in the medical community all the time is something that has to do with group beta streptococci. In pregnant women, we test for GBS, and we do this because GBS is a bacteria that is generally present in healthy individuals and about 25% of the population. And in an adult, GBS doesn't cause symptoms. You can still be relatively healthy and have this colonized in your colon or in your vagina. The problem comes when you deliver a baby and they go through the vaginal canal. They can get colonized by the GBS. And if they don't have maternal antibodies, or if it was a very long delivery where you ruptured your membranes for a long time, then the baby can become heavily colonized and they can't do anything about it. You know, their immune systems are not mature enough to handle it. So what they would do, the recommended protocol is to give 2 to 3 units of ampicillin intravenously while in labor. Now that recommendation can change based on different outcomes, but that is the general protocol for anyone who is GBS positive and in labor. And that's where I say antibiotics are used prophylactically. You're using these antibiotics, but you don't actually know that the baby has been colonized. You also don't know the other implications. Is this a fast delivery? Is this baby healthy? Is this baby preterm? There are a lot of things that dictate why this may not be a good idea or why it should be happening. So to combat developing antibiotic-resistant strains of group beta strep, I would suggest that instead of using this protocol for everyone, that we test early. And if someone comes up positive for GBS, then we can try to make lifestyle modifications like dietary changes that would get the microbiome of the individual looking more healthy, and you'd have more beneficial bacteria. And generally, when we get more beneficial bacteria, we can change the dynamic of the community that's in our gut and in our vaginal areas. And then, of course, I would expect that testing would continue to see if those dietary changes and lifestyle changes have made an impact. And then you can still continue with the normal 36 to 38 week testing of GBS and then reevaluate at that time. The other thing that I've noticed that a lot of healthcare settings don't really evaluate are maternal antibodies. And these can be passed passively to the fetus. Now, there's not a whole lot of research being done on this idea. I think that there's a lot that we can do in order to prevent antibiotic resistance from developing in this bacteria. So to leave off, I think that number one, we really shouldn't be doing antibiotic treatment unless there's a life-threatening situation. We shouldn't just be doing it for symptom relief. Number two, if it gets to the extent where you would need to take a course of antibiotics or someone in your family needs to take them, I would encourage you to take it exactly as prescribed or encourage your family member to do so. And number three, I really feel like we need to evaluate how we use antibiotics, and if there's a way that we don't have to use them as frequently, I think that that is the route we should go, because it may help in the short term, but in the long term, it has repercussions. And we've seen that in many situations with antibiotics. Thanks for watching.